Okay, hi, I'm Jess Monis. Just want to say hello to everybody. I come from Phoenix, Arizona, where it's a little bit hotter than here, if you can imagine that. So I'm a senior associate consultant and one of the physicians that work in the emergency department at Mayo Clinic. As Dr. Henry alluded to, right? He said it was one of the overrated things that we have, so that's where I work. Thank you, Dr. Henry. Okay, so what we're going to do is we're going to talk about the critically ill medical patient. Now, this is a huge topic, right? I mean, most of the patients that we see are critically ill, but what we're going to do is we're just going to target a few, case studies and take a look at it and try and hit on some high notes of patients that we see quite often. Okay, so we have a patient here. This is a 67-year-old man who's coming in with shortness of breath. He's been short of breath for the past couple days. He wakes up gasping at night. He's more short of breath when he lays down. You see he has vital signs here. So he's hypertensive, he's tachycardic, he's tachypnic, and he's a little hypoxic. Okay, so now you take a look at the patient. So what do you guys note here? What are we looking at here that's concerning? Right, he's got JVD, right? His jugular is like huge, it's up to the angle of the mandible, and it's pretty concerning. What else do you guys expect that you'll find on physical exam? Leg swelling, right? What are you going to hear in the lungs? Yeah, you're going to hear rales, right? You're going to hear crackles in the lungs. So this is what we're going to hear. And what does this patient have? Yeah, CHF exacerbation or acute decompensated heart failure, right? So that's what we're looking at here. Okay, so we're going to kind of hit on some high notes here, or some tests that we do, some diagnostic studies, things that we can do to help us with this diagnosis. Sometimes it's really clear, sometimes it's a little bit more difficult. So one of the things that we often will order, I order it sometimes too, it's a BNP, right? But how useful is this? So the studies are really all over the place. Some of the studies say, oh yeah, BNP can be useful. Other studies say, no, BNP is not really useful. Some say it can save you cost, right? Saves money. Others say, no, it actually increases money in the long run. So these are really all over the place. Now, when you have a BNP that's somewhere in the middle, that's really not as helpful to us. But sometimes in certain situations, it can potentially be helpful. And that's when you have a BNP that is, let's say, completely flat, right? If your BNP is completely negative, you can probably say with good certainty that the patient does not have a CHF exacerbation. The issue with that is that usually that goes along with your clinical gestalt. There may be some patients, however, that are kind of in the middle where you're like, well, the guy's a smoker, but he also has a little heart failure. So is it COPD or is it CHF? I'm not really sure. So in that patient, maybe that can be helpful, because if you have a BNP that's flat in that case, then you can say, okay, this is probably the COPD exacerbation. It's also important to remember that your BNP could be elevated for all sorts of reasons. What are some reasons you might see an elevated BNP? Renal failure, yeah, absolutely, right? You can see it in renal failure. You can see it if a patient has atrial fibrillation. You can see if a patient's super sick, right? So if they're septic, you can see it. Patients who have burns, you can see it. So really, it could be elevated for all sorts of things. So that's important to consider also. So it may make it less helpful. Age, body habitus, and gender can sometimes change it, and oftentimes labs will adjust your BNP based on age. So you'll see that the upper limit of normal will change depending on how old the patient is, so sometimes lab can help you with that. So what do you think is more helpful than a BNP? What can be more helpful? This is kind of like a what am I thinking thing, but you're in the emergency department, right? You have some tools, some diagnostic tools at your fingertips, at your bedside. What can you grab and put on the patient that may be able to help you and give you a clue? Ultrasound, right? I feel like the answer to that question is always ultrasound. Anytime somebody's like, what else can you do? It's always grab the ultrasound. If you say that, you'll be right 80% of the time. It's like the 80-20 rule, right? Okay, so here we are. What is the arrow pointing to? What are we looking at here? What are these called? B-lines, absolutely. They're called B-lines, right? And B-lines are this hyperechoic kind of artifact, right, that can happen when the sound waves hit fluid. Okay, so that's what you're seeing over here. So we're looking for this artifact to help us make this diagnosis. And in order to make the diagnosis, what we're doing is we're looking for more than 3 B lines in both lung fields, right? And if we see that, we can say with pretty good certainty that this is a CHF exacerbation. And in fact, there was a recent meta-analysis that looked at 6 studies with over 1,800 patients presenting with shortness of breath. And they compared lung ultrasound to chest x-ray, and they found that lung ultrasound had a better sensitivity, 88% versus 73% with the chest x-ray. Okay? So the ultrasound is actually better than chest x-ray in assessing for CHF. There was another randomized controlled trial that looked at 500 patients presenting with shortness of breath, and what they found is that an ultrasound, but not chest x-ray plus BNP, helped with your diagnostic accuracy, okay? So better than the BNP is the ultrasound, so certainly grab it because that can help you. Okay, so we're gonna get a chest x-ray on these patients, right? We're gonna do it. This is, I don't think you're gonna get a patient admitted without a chest x-ray if they've come in with shortness of breath. And that's okay. Sometimes it can help you, sometimes you can see it, but it's really important to know that about 20% of patients presenting with acute decompensated heart failure may have a normal chest x-ray. So don't let that necessarily reassure you. But it can be helpful because you can see other things, right? You can see a pneumonia, you can see a pneumothorax. Sometimes if you see hyperinflated lungs, you could say, oh, this patient looks like they have COPD. So it can certainly help you with those other things. The radiation is pretty low, so I would certainly get it. Okay, so we're gonna talk about non-invasive positive pressure ventilation. So if you get a call that your patient's coming to the ED and they're short of breath and they're in respiratory distress and EMS is worried, get respiratory therapy down there, right? Just say, bring your CPAP, bring your BiPAP, get it down because we may need to use it. Better to have it, handy. So this delivers pressurized gas during inhalation, and this can help decrease the work of breathing, can help make patients feel a lot better. But you want to make sure to use this in caution in patients who have altered mental status or if they're vomiting. And the reason why is because the last thing you want is somebody to vomit into their, like BiPAP or CPAP and then aspirate, and then you get a whole slew of other problems, right? Okay, so let's talk about high flow nasal cannula. How many of you guys have this at your facilities? So a handful. And oftentimes hospitals will have it, but we don't necessarily have it that readily available in the emergency department. So this delivers humidified oxygen up to 60 liters per minute, okay? So, we got nasal cannula at 2, this is 60. This does not mean that you just take your nasal cannula, you stick it to the, the wall oxygen, and you crank it up, right? It's different. These are special machines that do it. But sometimes they can be helpful, and the thought process is that they can decrease the dead space, okay? They can give you a little peep, and it's supposed to be more comfortable. So this study over here, this is a randomized study of about 200 patients, and what they did is they looked at high flow and they compared it to BiPAP. And what they said that in the high flow nasal cannula group, that there was a 10% more failure rate. So I want to just explain that to you because they considered a failure rate moving from high flow nasal cannula to BiPAP. I don't consider that failure, right? I consider it, you tried something that was a little less invasive and that didn't work, so then you amped it up a notch. So to me, that wasn't a downside. And in fact, they found that in the high flow nasal cannula group that there were 6% less intubations. So I think there probably needs to be more study and more data out there, but I certainly think it's reasonable to try. Okay, so the thing that we always grab in these cases is nitrates, right? This is our mainstay treatment for acute decompensated heart failure. So this can decrease preload. So, you really want to use with caution in patients that are preload dependent. So things like aortic stenosis, RV infarcts, tamponade. And what's the medication you always want to ask the patient they're taking before you give them a nitrate? Viagra, exactly. So that's kind of the thing you want to ask. So remember that a sublingual dose is higher than the drip when you first turn it on. So what I always do for patients is I grab a couple, I give them a couple doses of the sublingual while I'm getting my drip started. And then you kind of give them a whole big, dose up front. And then what you do is you start the drip and you just, you crank the drip up, You crank it up and then you can come down. So titrate up quickly and then come down as needed, based on pressure and based on patient clinical improvement. And the other thing that I just want to mention is that the nitro paste, I'm not a huge fan. I think, the absorption is erratic. And I think then what happens is the patient's pressure drops and then you're trying to wipe it off. You're trying to clean the patient. You're better off going with something that you know exactly the dose they're getting and how to titrate it. So stick with the sublingual, stick with the drip. Okay, so loop diuretics. So this is a recommendation from the American College of Cardiology as well as the American Heart Association. They're from the 2013 heart failure guidelines. And they say that patients should be diuresed, right? If they have signs of fluid overload, they should be diuresed. You certainly want to use this in caution if patients are presenting hypotensive or in cardiogenic shock. And again, be careful with things like aortic stenosis. You want to give bolus dosing for these patients. But it turns out that the bolus dosing you give doesn't really matter. They've done studies looking at low dosing versus high dosing, and it turns out it doesn't make a difference. So pick whatever you're comfortable with. I was trained, you take 40, you multiply it by the creatinine, and that's what you give, right? So everybody's got their own thing, but it turns out it doesn't really matter, so don't really worry too much about it. Okay, so this slide says that morphine is controversial. Morphine is always controversial. It's not always good for what ails you. There was a systematic review that found no benefit and maybe some harm in its use, so I would certainly use it with caution. The largest study looked at 150,000 patients, and they found increased frequency of mechanical ventilation in these patients, admission to the ICU, and increased hospital mortality. And the study that we're looking at here also was associated with an increased 30-day mortality. So I wouldn't necessarily reach for morphine in these patients. Okay, so now we take a look, right? So we got a patient now who is tachycardic. Okay, now they're hypotensive. They're still hypoxic, okay? So the thing that we worry about these patients is cardiogenic shock, okay, right? Cardiogenic shock is a pretty scary thing. The important thing in patients with cardiogenic shock is we need to support them. We need to give them pressure support. These patients often end up going for balloon pumps. You can start with some non-invasive positive pressure ventilation, right, to help decrease the work of breathing and help get them a little bit better. And then what you can consider for their pressure is you can start them with a little norepi, okay, to get their MAP maybe like greater than 60. And then you can start some inotropy, so give them some dobutamine, okay, help them with the squeeze, help them better perfuse their body. So super important. Okay, so just a little summary slide for acute decompensated heart failure. Nitrates, 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 right? We said this is the mainstay. This is what's going to help your patients feel better, so make sure to give it. Start with sublingual and then give IV. Non-invasive positive pressure ventilation, start it early, right? Don't wait, get respiratory therapy down there and do it. Start with your high settings for these, for both the nitrates and that, and then you can decrease it as needed. Give them some Lasix, whatever the dose, choose it, doesn't really matter, but just give it, and then manage their cardiogenic shock. Okay, so we're going to switch gears a little bit here, and we're going to talk about a different type of patient. So let's say you have a 37-year-old patient who's coming in with shortness of breath and wheezing. All right, they're in respiratory distress. You're trying to get a history, but it's really difficult because they're only talking one-word sentences. And, you kind of look through the chart and you see that this patient has been intubated twice before, right? So that should kind of get you super concerned. What does this patient have? Asthma, right? This is an asthma exacerbation. And, anyone who's been intubated for an asthma exacerbation, you know that they have super, super bad asthma. So what's the first thing you want to do for these patients? What do you want to start them on? Yeah, nebulizer, right? Give them some nebs. Start a continuous treatment, okay? So give them some albuterol, give them some ipratropium, and get them feeling better there. While you're doing that, stick it in IV, okay? You want to send labs because you think they're getting admitted and hospitalists won't admit them without them. Fine, but do not waste your time, right? This is not going to make these patients feel better. You're not going to learn anything here in a blood gas that's going to help you manage this patient. These asthma patients you manage clinically, right? Based on what you're seeing. They will clearly show you how bad they are. Also give them IV steroids, right? So give them some methylprednisolone. The other thing you want to do for these patients is you want to give a MAG. How many of you guys are routinely giving MAG to your severe asthma exacerbations? That's great. We're going to talk about this in the next slide, but it's great that you're doing that, and you can certainly consider epinephrine. The thing you do not want to do for these patients is you do not want to intubate them, okay? Intubating asthmatics is bad. Bad things happen. It is definitely a last resort here. Okay, so here's a study that looked at magnesium as a bronchodilator. Okay, and you can give 2 to 4 grams over about 20 minutes. And this looked at 7 RCTs. This was a Cochrane review that looked at 7 RCTs, almost 700 patients, and they gave IV magnesium versus placebo in patients with severe asthma exacerbations. And they found that peak flow improved, okay, the forced expiratory volume improved, and admission rates decreased. And take a look over there. The number needed to treat is 2, right? This is good. This is good stuff, so you should give that. Okay, so what if the patient isn't getting better? Can you give them some BiPAP, right? Can you give them some BiPAP or some CPAP or something like that? So there's been some small randomized studies and one meta-analysis. One of the small studies had about 30 patients that did show some benefit, okay? It reduced rates of hospitalization by 40%, not too bad. And increased lung function, okay, from 80%, increased lung function to 80% versus 20% with the FEV1. You need larger trials to see this, but I certainly think it's reasonable, right? Anything to stave off intubation, if you want to try it, I think that's totally okay. So what are some other agents that we can use, okay? Consider ketamine. This is something that you got to be careful with, because sometimes a nurse may come to you and just say, I just think this patient is anxious. Could we just give him some Ativan? Sure, you want to kill the patient? Give him Ativan, right? Never give your asthmatics Ativan, but you can give them some ketamine, because with ketamine you can get some bronchodilation, but it can also take the edge off. So certainly reasonable to consider. They suggest 0.3 milligrams per kilogram, to a max dose of 25, takes the edge off, sometimes helps them. Heliox. So I remember when I was training, it was like, Heliox, reach for Heliox. Heliox is so great. But it turns out the studies didn't really, pan out for this. So the one thing Heliox can be used for is it can be used as a delivery agent. So if you're giving Heliox with something like albuterol, that can potentially be helpful. But Heliox alone, they thought it decreases turbulent flow, gets where it needs to be, not really that beneficial. Okay, and then epinephrine. So epinephrine is a potent vasoconstrictor. It decreases edema. And there was a systematic review. So the issue is there's a systematic review that showed no significant benefit when it compared to bronchodilators. But it's certainly reasonable to try. So just remember the dosing. So it's 0.3 milligrams of the 1 to 1,000 formulation, okay? So I don't know why they make epinephrine so confusing, right? You got 1 to 1,000, 1 to 10,000, use 0.3. It's very confusing. It's like the medication that when stuff hits the fan, right, and everything's chaotic, and you need one thing, why does that one thing have to be so confusing, right? Why can't it be simple? Anyway, but you can certainly try it. If you're going to give it IV, just know there's very little data published on it, but the study that they're showing here said it was safe for use, so certainly reasonable to consider. Okay, so now intubation. Remember, avoid intubation at all costs. This is the last thing that you want to do to these patients, okay? It's not going to fix the underlying problem, and it can potentially make it much worse if the vent settings are not managed well. You want to pre-oxygenate these patients. In fact, if you have high flow oxygen, stick it on the patient. Okay, the high flow nasal cannula can help. If you don't, in this situation, I'd probably put the nasal cannula and just crank it up, right? So you want to do the apneic oxygenation, so keep that oxygen on while you're intubating. So when you're going to induce the patient, this is a great time to give ketamine, right? So give ketamine with your paralytic. Obviously, in every intubation, make sure to have your airway, your backup airway ready, and then be prepared for complications. So the problem is with these patients is when you intubate them, you can get breath stacking, okay? And with breath stacking, you can get pneumothorax. And what happens to a pneumothorax in an intubated patient? What happens? Yeah, it becomes a tension pneumothorax, exactly. So, they're saying you can use permissive hypercapnia. Don't focus too much on the numbers there. If you're going to try and get that PCO2 down, right, you're going to end up probably killing the patient before you do that. okay? So the thing that you need to have here is you need to have a low I to E ratio, which means that, the inspiration component, like you can, if the inspiration's 1, the expiration can be 3, right? Because these patients, they have obstruction, it's hard to get the air out. So it's important to make sure that you give them plenty of time. If you do not give them plenty of time, again, you'll see breath stacking, and that can lead to big problems, right? You can blow their lungs out, so be careful with that. And so you want to set the rate low. You want to set it like 6 to 8 breaths per minute to give plenty of time for expiration. And, you could titrate up the oxygen. It doesn't have to be 100%. Anywhere north of 90 is probably good. And, for these patients, you want to use low PEEP, okay? Like, again, you don't need high PEEP for these patients. And, again, be careful, watch out for breath stacking. And sometimes, if you're having problems ventilating the patient, this is the situation where sometimes they'll disconnect the patient, and you'll just grab the lungs and kind of get everything out and take some time before rehooking them up. Okay, so summation for severe asthma. So mainstays, bronchodilators, albuterol and ipratropium as a continuous nebulizer. Just give it, tons of it. Give IV steroids early, okay? Give magnesium early. You can try non-invasive positive pressure ventilation. I think there's really low downside there. So if they can tolerate it, certainly try it. It can help them with their work of breathing. This is a great time for ketamine. So if if they're like patients feeling anxious, or the patient tells you they're feeling anxious or they need some help, you can try ketamine, which can give you some bronchodilation. Certainly epinephrine, right? I mean, you can give a dose of IM-epi, see if it makes them feel better. Sometimes it does. And again, intubation, last resort. Okay, so our last case here, we're going to switch gears a little bit. So we're going to talk about something else. So you have a patient here. It's a young guy. Well, let's say he's like 27 years old, okay? He comes in with abdominal pain, and he's complaining. I feel like this slide gives it all away, but he's complaining of abdominal pain. He's got nausea and vomiting, and then, sure, he tells you he has polydipsia. I mean, I don't know. How many patients tell you they have polydipsia? Not unless you ask, right? That's not something that's just like, and I'm thirsty all the time, doc. Oh, yeah, and I have diabetes, and I haven't taken my medication. So what does this patient have? Yeah, probably DKA, right? They have a hyperglycemic crisis, probably for sure. What's the first thing you want to get on these patients? Yeah, get a glucose, right? Get a finger stick. Let's see what's going on with them. So you take a look at the vitals here. This guy's a little hypotensive. He's super tachycardic. All right, he's satting like 92% on room air. He's somnolent but arousable, right, to stimuli. Dry mucous membranes. The guy basically looks like crap, right? He looks pretty terrible. Okay, so the first thing you guys said you wanted to do is you wanted to get a glucose. Excellent, right? What's the first thing you want to give this patient? Fluids, right? These patients are massively volume down. So give them fluids, okay? So start a line, give them some LR, you can give them some normal saline, but give them fluids, give them something, right? You can give them some supplemental oxygen if they're a little hypoxic, if their O2 sat is down. All right, you want to check labs. So certainly reasonable. You want a BMP, right? We're checking to see if they have an anion gap. You want to get a VBG, okay? This is a great time. You want to see if they're acidotic. UA, if they're symptomatic, you can certainly do that. If you can look for ketones, you can get a beta hydroxybutyrate, depending on what your facility has. Now you want to look for, why is this patient in DKA? So sometimes they're in DKA, like this guy who just doesn't take his medication, right? But other times it could be maybe they have an illness that precipitated it, so maybe we get a chest x-ray, maybe we get a UA, right? If they're super tachycardic, get an ECG, look to see if they have an arrhythmia. Okay. So now we take a look at this blood gas, and we see that the patient has pH is 7.09, right? And you take a look. So clearly, what does this patient have now? DKA, right? Bicarb's low, have DKA. Okay. So should you put this patient on an insulin drip? How many people would say, "Hey, this guy's got DKA. I'm going to start an insulin drip right now"? Good, okay. And why not? What are we waiting for? What do we want to know? The potassium, absolutely, right? You want to know the potassium because what happens is when you start the insulin, right, it's going to shift the potassium into the cells, and this can precipitate, cardiac arrhythmias. This is real. This has happened, okay? The insulin is not the important thing right off the bat with these patients, it's the fluids. So I would certainly want to hold off and wait on that. Okay, so in terms of potassium, the American Diabetes Association, they have an algorithm for the treatment of DKA, right? Everything is laid out for you. So it tells you here that for potassium less than 3.5, hold the insulin, give it a minute, right? Give them some potassium back. You want to give them some magnesium too, because remember, without magnesium, you're not going to increase your potassium. So patients who have hyperglycemic crisis definitely want to check all their electrolytes, including the mag. And then if the potassium is between 3.5 and 5, you can start the insulin, but make sure to give them the potassium as well, because you're going to see their numbers, the potassium decline as you give it. And for potassium greater than 5, you can hold off the potassium for now and recheck it every couple hours. Okay, so after that, when you want to give the insulin, you can do it at 0.1 units per kg per hour. I think boluses have pretty much fallen out of favor. Is anyone using boluses anymore? Not really, right? I mean, even a couple of years ago, I was fighting endocrine in my other hospital because they wanted to keep the bolus on their order sets, and I was like, you want to have it as a line, have it as a line, but don't make it a pre-check, right? We're not doing this anymore. We're really not doing this anymore. So once the glucose is less than 250, you want to give them some sugar back, so you can give them D5 half normal. And when their labs normalize, then we can say that we have some resolution here. So we're going to summarize this for DKA. So remember, the important thing for DKA patients is fluids, fluids, fluids. These patients are massively volume depleted. Hold the insulin drip until you know the potassium. If you have iStats at your facility, get an iStat BMP, see what their potassium is. Don't forget to replete the potassium. Even if they have a normal potassium, you have to give potassium back to these patients if it's less than 5. Don't forget your IV magnesium either. Initiate the insulin drip. You don't need a bolus. And you know what? Follow the 88 algorithm, because it's there for you. It makes it easy. And with that, I thank you very much, and we will give the floor over. So thank you.